Welcome back to Studious. The human body holds most of its critical structures completely out of sight, deep beneath skin, fat, fascia, and muscle. So how does a clinician know exactly where to press, listen, inject, or incise without opening the body up? The answer is surface anatomy, a precise coordinate system built from visible and palpable landmarks that map everything below. The thorax, the back, and the upper limbs are three of the most clinically active regions in the entire body, packed with diagnostic targets, injection sites, auscultation windows, and vascular access points. In this video, we are going to systematically decode every major surface landmark across these regions, from the suprasternal notch at the top of the chest all the way down to the gluteal foundation of the posterior trunk. Think of this as your clinician's navigation guide. Let's start mapping.
Before we dive into specific landmarks, it's important to understand why surface anatomy exists as a discipline in the first place. Most anatomical structures, the heart, the lungs, the great vessels, the brachial plexus, are completely hidden from direct view. Surface anatomy provides the visible and palpable reference points that allow clinicians to locate these structures accurately without imaging. There are 5 core techniques that rely on surface anatomy knowledge: palpation, which is touch-based mapping of underlying structures; percussion, which tests tissue density through sound; auscultation, which uses a stethoscope to detect acoustic signals from organs; inspection, which reads the surface visually; and function testing, which reveals dynamic muscular and joint anatomy through movement. Every one of these techniques depends on knowing exactly which surface landmark corresponds to which deep structure. The surface is the interface between the clinician and the interior of the body.
The upper thorax is organized around 3 foundational bony landmarks that every clinician must know cold. The first is the jugular notch, also called the suprasternal notch, the small but easily palpable depression at the superior border of the manubrium, right at the base of the neck, between the 2 SCM tendons. It's the starting reference point for the entire sternum. Lateral to it, the clavicles sweep outward in their characteristic S-shaped curve, acting as the skeletal foundation of the shoulder girdle and serving as attachment points for critical muscles and ligaments. At the far lateral end of each clavicle, where it meets the acromion of the scapula, lies the acromioclavicular joint, a distinct bony protuberance on the top of the shoulder that is easily palpated and frequently injured in contact sports and falls. Together, these 3 landmarks, the jugular notch, clavicles, and AC joints, form the complete superior boundary of the thoracic cage.
If there is one landmark on the thorax you absolutely cannot afford to miss, it is the sternal angle, also known as the angle of Louis. This is the synarthrotic joint between the manubrium and the body of the sternum, felt as a distinct transverse ridge on the front of the chest, roughly 5 centimeters below the jugular notch. Its clinical value is extraordinary. In the horizontal direction, the sternal angle sits at the exact level of the second costal cartilages and the second ribs bilaterally, making it the definitive starting point for rib counting. When you need to find the 5th intercostal space for cardiac examination or the 4th intercostal space for chest drain placement, you always begin at the sternal angle and count downward from there. In the posterior direction, the sternal angle corresponds to the level of the intervertebral disc between T4 and T5, the key spinal level marking the division between the superior and inferior mediastinum. 1 landmark, 2 vectors, enormous clinical power.
Moving to the lower thorax, 4 landmarks define the inferior boundaries of the chest and allow clinicians to map the viscera beneath. The costal margin is the inverted V-shaped bony border formed by the lower costal cartilages as they converge on the midline. It marks the approximate surface position of the diaphragm and is a critical surgical landmark in abdominal and thoracic approaches. At the very bottom of the sternum, where the 7th costal cartilages meet, lies the subcostal angle, or infrasternal angle, marking the xiphosternal joint. For rib palpation, a vital clinical rule applies. All ribs from the second downward can be individually palpated by working laterally from the axilla downward
except the first rib, which is shielded from access by the overlying clavicle. And running vertically down the center of the sternum, the mid-sternal line is the imaginary reference used to locate the cardiac apex, found precisely at the fifth intercostal space, 9 centimeters to the left of this line. That is exactly where you place your stethoscope to hear the apical beat.
The anterior chest wall is not purely bony. It carries important soft tissue layers with their own surface anatomy and clinical significance. On the muscular side, the pectoralis major forms the dominant anterior contour of the chest, creating the bulk and shape of the pectoral region visible from the front. Just lateral to it, and below the axilla in well-trained individuals, the serratus anterior becomes visible as a series of muscular slips along the lateral chest wall, a key landmark for assessing long thoracic nerve integrity, as winging of the scapula results from serratus anterior paralysis. On the glandular side, the mammae are prominent surface features in females, and the nipple areola complex serves as a central visual landmark. The inframammary region, the topographic zone directly beneath the breast, is a defined surgical boundary relevant in breast surgery and chest-drain insertion. In males, the nipple typically overlies the fourth intercostal space, a useful cross-reference for cardiac examination and thoracic procedures.
The proximal upper limb is dominated by 3 dynamic muscular landmarks that change with movement and activation. Viewed anteriorly, the biceps brachii, a 2-headed muscle running down the anterior arm, creates a highly prominent, easily visible elevation, especially during elbow flexion or when the hand is clenched tightly. The biceps tendon is palpable in the cubital fossa and is tested in the biceps reflex. From the lateral view, the deltoid wraps around the entire proximal humerus, taking its name from its resemblance to the Greek letter delta in cross-section. It attaches to the acromion, the clavicle, and the scapular spine, and forms the rounded contour of the shoulder. The deltoid is the primary site for intramuscular injections in adults. From behind, the triceps brachii creates a distinctive upside-down U-shaped surface contour on the posterior arm when contracted, produced by the visible tendinous fibers beneath the skin, converging on their insertion at the olecranon. All 3 muscles are dynamic landmarks. They reveal themselves fully only through activation.
2 anatomically distinct regions of the upper limb deserve special attention for their clinical relevance. The axilla, commonly called the armpit, is located directly beneath the glenohumeral joint at the junction between the upper limb and the thorax. It is characterized by its high concentration of apocrine sweat glands, producing its typical features of hair growth and body odor. But clinically, the axilla is far more significant as the region through which the major neurovascular structures of the upper limb pass, the brachial plexus and axillary vessels, and as the primary site of axillary lymph node drainage, critical in breast cancer staging. At the opposite end of the arm, the olecranon of the ulna forms the bony point of the elbow, the most prominent posterior landmark of the forearm. It serves as the attachment lever for the triceps brachii, enabling elbow extension. Its superficial position, while making it easily palpable, also makes it highly vulnerable to direct trauma, olecranon bursitis, and fracture from falls on an outstretched arm.
Nowhere in the upper limb is the clinical density of surface anatomy more concentrated than in the cubital fossa, a small triangular depression at the anterior elbow, also called the antebrachial fossa. Located at the inferior insertion of the biceps brachii tendon, this region is a gateway for 3 critical clinical procedures simultaneously. First, for blood pressure measurement. The stethoscope is placed directly over the brachial artery as it passes through the cubital fossa to auscultate carot cough sounds during cuff deflation. Second, for venipuncture. The superficial veins just above the cubital fossa, including the median cubital vein, are the primary sites for routine blood draws and IV cannulation. Third, for pulse palpation. The brachial pulse can be manually detected here by pressing lightly medial to the biceps tendon. The forearm itself is divided into 2 visible muscle compartments, a larger lateral group that creates a thickening along the radial aspect, and a smaller but palpable medial group.
Knowing this region in detail is essential for every healthcare professional.
Turning to the back, the superior dorsal surface is organized around three primary landmarks. At the very top of the spine, where the neck meets the back, the vertebra prominens, the spinous process of C7, stands out as a sharply palpable bony bump. With a longer spinous process than any adjacent vertebra, C7 is the single most reliable starting point for spinal level counting from behind. Any spinal procedure, injection, or vertebral level assessment on the posterior trunk begins here. Covering the majority of the upper back is the trapezius, a massive diamond-shaped muscle spanning from the external occipital protuberance superiorly to the lower thoracic spine inferiorly and out laterally to the shoulder. It defines the slope and contour of the upper back and neck. Running vertically down the full length of the back, the spinal furrow is the continuous longitudinal groove formed by the spinous processes and the flanking erector spinae muscles on either side. Remarkably, the spinal furrow is clearly visible in virtually all individuals, regardless of body fat percentage, making it one of the most universally reliable dorsal surface landmarks.
The scapula is a highly mobile bone, and its surface landmarks shift dynamically with arm position, a critical concept that is frequently overlooked. Three scapular features serve as reliable reference points: the spine of the scapula, the medial margin, and the inferior angle. The spine runs horizontally across the posterior scapula and is easily palpated as a sharp ridge. The medial margin runs vertically parallel to the thoracic spine, and the inferior angle, the lowest point of the scapula, typically lies at the level of the 7th or 8th rib and shifts upward when the arm is raised. Because the scapula moves, these landmarks shift dynamically, especially when the arm is extended forward, a fact that must be accounted for during clinical examination. Between the medial scapular border, the lower trapezius, and the latissimus dorsi lies a region known as the triangle of auscultation, a zone where the back musculature thins significantly, creating an acoustic window directly over the posterior thorax. Clinicians position the stethoscope precisely here to hear respiratory sounds from the lungs with significantly greater clarity than anywhere else on the back of the body.
The lower back and pelvic region carries its own set of distinctive surface landmarks with significant clinical and anatomical relevance. The rhombus of Michaelis is a diamond-shaped surface contour visible on the lower back, formed by the posterior superior iliac spines laterally, the last lumbar spinous process superiorly, and the beginning of the gluteal cleft inferiorly. It is classically studied in obstetrics and midwifery, where its symmetry and shape are believed to reflect the architecture of the pelvic inlet and carry significance for the mechanics of normal childbirth. The dimples of Venus are two small symmetrical depressions flanking the lower lumbar spine, marking the exact points where the sacrum attaches to the ilium, the sacroiliac joints. These dimples are genetically determined and therefore not visible in all individuals. Finally, the sacral triangle is the visible surface region directly overlying the sacrum, the large triangular bone that forms the posterior wall of the pelvis and the base of the spine. These three landmarks together define the lumbosacral junction on the surface.
The gluteal region forms both the inferior boundary of the dorsal trunk and a region of significant clinical importance for intramuscular injections, nerve anatomy, and surgical access. The shape of the buttocks is created by three layered muscles: the gluteus maximus, the largest and most superficial, responsible for the dominant posterior bulk; the gluteus medius, sitting superolaterally beneath the maximus and contributing to the lateral hip contour; and the gluteus minimus, the deepest and smallest of the three. Together, they form one of the most powerful muscle groups in the human body, responsible for hip extension, abduction, and stabilization during gait. On the surface, two topographic borders define the gluteal region: the gluteal sulcus, which is the horizontal fold at the inferior aspect of the buttocks, where the thigh begins, and the intergluteal cleft, the vertical midline groove separating the two sides. Clinically, the upper outer quadrant of the gluteal region is the safest site for gluteal intramuscular injections, avoiding the sciatic nerve, which passes through the lower medial quadrant.
Now, let's synthesize the key junctional regions, the clinical hotspots where multiple surface structures converge to create windows of diagnostic access. The sternal angle is a synarthrotic skeletal junction that provides rib counting access to the second ribs and posterior spinal mapping to the T4-T5 level. The axilla is the limb to thorax junction, providing access to the brachial plexus, axillary vessels, and the lymph node chains critical in oncological staging. The cubital fossa is the muscular and tendinous insertion triangle at the anterior elbow, the clinical gateway for blood pressure measurement, venipuncture, and brachial pulse detection simultaneously. And the triangle of auscultation at the medial scapular border is the muscular thinning zone that provides the clearest acoustic window to the posterior lung fields. Each of these 4 fossae and junctions is a convergence point, a place where anatomy organizes itself in a way that makes clinical access both possible and precise. Mastering these 4 areas alone will dramatically elevate your clinical examination skills.
Let's bring the entire surface anatomy of the thorax, back, and upper limb together into one integrated examination framework. Surface anatomy is an interconnected system where bony prominences serve as static anchors and muscular contours serve as dynamic access points. For auscultation, lung sounds are best heard through the triangle of auscultation at the medial scapula, while blood pressure requires the stethoscope over the brachial artery in the cubital fossa. For palpation, the brachial pulse is found in the cubital fossa, and rib counting always begins at the sternal angle, the angle of Louis. For venous access, the superficial veins just above the cubital fossa are the primary target for cannulation and blood draws. For visceral mapping, the cardiac apex is located at the 5th intercostal space, 9 centimeters to the left of the midsternal line, and the diaphragm is approximated by the costal margin. Every clinical action on the thorax and upper limb links back to a surface coordinate. Learn the map, and the examination becomes not just systematic, but intuitive. Keep studying with Studious, and we'll see you in the next one.